Hello and happy Teach Me Tuesday. My name is Lisa Houston and I'm a clinical nurse educator specializing in NICU education here for this week's Teach Me Tuesday. As you know, in January we are doing a back to basics kind of idea as we settle back into a new year. And today we're going to talk about auscultation and its importance in assessment. So back to basics, January's kind of all been about assessment. Our first week we did kind of what are we looking for in assessment? Then we focus on respiratory assessment, and today we're going to focus on auscultation. So let's dive in here. So auscultation is kind of one of those things. We, of course, do palpation as NICU nurses, but probably not as much as adult nurses do. And TBH, I can't really remember what adult nurses do because it's been so long since I was in nursing school because I'm old. But the general idea is we use auscultation a lot, especially with our respiratory and abdominal assessment, and with our heart assessment as well, but respiratory, huge part of it, right? We are looking for those subtle changes that could be telling us that something major is going on with our babies. We also want to know these concerns early, and we want to be able to recognize when those minuscule changes are happening, such as something that could tell us the baby has a pneumothorax or a heart murmur. So listening to your babies frequently throughout your shift, those kinds of things are going to help you be successful in recognizing changes early. And once we kind of recognize what the baseline is with auscultation, it's going to help us recognize those changes. So let's start with what is normal? What should we be hearing when we're listening? So on our heart sounds, which this was by far the hardest part of a transition to a NICU nurse. I became a NICU nurse about 21 years ago. This week, somewhere around the 20th of January of 2004. And I remember listening to a micropreemie's heart for the first time. It was beating 160, 170 times a minute. And I was like, let's just break this down. How am I supposed to be differentiating all of these heart sounds, all these things that could be going on? I will never hear a murmur in my life. And all that didn't happen, right? As I became more proficient as a NICU nurse and I had worked there for longer, I did learn how to listen to those S1 and S2. I have been able to hear murmurs. I will say I am not your murmur girl. You don't come to me and say like, oh, this is what I'm hearing. What is that? I can tell you if the baby has a murmur, but I'm not an expert in that. I love cardiac ICU nurses. They are great at that. So give yourself some grace. Know that what you're hearing is going to be very fast and you really need to pause and listen. I am so specific with my stethoscope and how I hold it when I'm listening. If you see me really focusing, I will kind of close my eyes and I pull the stethoscope out. And I think it's just the way that it's going into my eardrums that makes it much easier for me to hear what's going on. So recommend finding what works best for you when you're listening. As far as lung sounds, we want clear, equal, bilateral, smooth movement of air in and out, which I'm sure you do hear on a baby, especially if you're taking care of a term baby, maybe a kid that's there for sugar, a late preterm infant, even a smaller baby that's kind of doing well. But in general, this isn't always our baseline, so knowing what your infant's baseline is going to be crucial. And then our bowel tones, I also remember this idea of like, how will I ever know what 4-quadrant is? 4 quadrants don't really exist well on a small micropremature baby. Even a term baby, you could maybe say you don't hear it here, but it's going to reverberate so much throughout there that we don't focus as much on quadrants, just on how frequent are the bowel tones. So listening to all of those different things is going to help us know what's normal and what's abnormal. So let's break down our heart sounds. Again, as I mentioned, murmurs is going to be this swishing or whooshing, a washing machine sound that you're going to hear in between your S1 and S2 or outside of your S1 and S2. Most likely you're going to hear a PDA murmur. That is the most common murmur that we hear in the NICU, especially if you're taking care of all of the spectrum of infants. And murmurs, PDA murmurs are often louder when they're closing, and that's because of the velocity of the blood that is passing through the actual opening of the ductus arteriosus is very forceful, and they can sound like that loud machine, whereas when it's wide open, the blood is able to flow more freely through, and it's probably not going to sound as loud, but the whoosh, whoosh will really be there. It's almost like it's more sharp when the murmur is smaller. And I wish I could tell you that every member is going to sound the same, but it's not. So just kind of be listening for variation in that S1 and S2. We also hear VSDs, ASDs, tricuspid regurgitation. If your baby has been in the NICU longer, maybe their heart is feeling some stress on it over time, you may also hear different heart sounds going on as the heart has taken on more work that the lungs are unable to do. So those are variations you could hear if you have babies that stay in your NICU past their due date, maybe up to a year, as I have worked in a NICU where the baby stayed until their first birthday or maybe beyond that. And we would hear different heart sounds kind of as that heart is being taxed from doing some of the work for the lungs. And then your VSDs, your ASDs, those are also other things you're going to hear in your variations. So let's talk about our lung sounds. We just have some examples in our x-rays here, but if you have diminished or absent lung sounds, you could have pneumothorax, as evidenced by this very first x-ray picture where we have a giant pneumothorax over there. You could have a displaced tube, and let's say maybe you're only hearing breath sounds on the right side. Maybe your ET tube has become right main stemmed, and so you do not hear breath sounds on the left. So that would be something to investigate. Atelectasis is kind of that shutdown of certain areas. So you might hear your breath sounds differently depending on the lobe. Crackles, we did talk about a little bit last week as well. It's kind of that popping sound you're going to hear during inspiration, and that's extra fluid on your lungs. So in this x-ray here, you can see that kind of that left lung has extra fluid. It's whiter on the x-ray. That's indicative of some fluid on your lungs. And then wheezes is those high-pitched musical sounds often heard during expiration. That can be caused by an airway obstruction, sometimes inflammation. In general, wheezing is not a great sound, right? There's some collapsing going on in there. And so we want to be able to account for that. So sometimes we can give them bronchodilators, or of course make sure that there's not an obstruction in your airway. And then our variation in our bowel tones. So in the NICU, since we can't necessarily say, oh, I hear it here or I hear it there, we really are looking for how frequently are they happening. So about every 3 seconds, 3 to 5 seconds is what you want to hear when you are examining your bowel tones through a stethoscope. They should be loud and not feel distant when you're listening. That could also indicate something's going on. If you're taking care of a baby with high drops, they might have extra fluid all over their body, and it could be harder to hear both lungs, heart, and bowel tones going on in there. You also want to know, I've been on a shift. I can remember it so distinctly for a baby I was taking care of in Seattle, where I heard bowel tones at my first assessment and I did not hear them at my last, and the baby did have neck. And so that is one of those things that you're recognizing that there was a change going on with your baby. All babies should have bowel tones. If they've been NPO for a period of time, they're going to get quieter. So if your baby's never eaten, it's never been stimulated, it is not abnormal to have infrequent bowel tones, especially in an NPO baby. That's kind of what we wanted to do. We want the gut to go on rest, right? Especially if a baby has concerns for neck. So keeping those things in mind and making sure we're escalating them, making sure when you're documenting, you can note frequent, infrequent, absent. Absent bowel tone should always be on your EHR, an option. Auscultation's tricky. I'm sure you've already noticed that. Like, how can we successfully do this if there's a ventilator? A high frequency ventilator, whether it's an oscillator or jet, it is very difficult to auscultate anything going on, which we talked about that last week a little bit. And how do we differentiate lung sounds on a baby on a jet? So if you haven't watched that YouTube video, go back and check that out, where we dive into there. If a baby's crying during your whole assessment, if your baby's even on bubble CPAP, sometimes it can be hard to differentiate. So making sure that if you're on high frequency ventilation, that we are pausing to listen. One person should definitely be listening, and then any time you see changes in your CO2 monitor, your oxygen requirements, apnea and bradycardia, making sure we're pausing and listening for that. If the baby's crying, we wanted to perform assessments during those quiet periods whenever possible. Maybe we can't get to their backs as easily. Maybe they can't be turned, so we're not able to, assess all the areas. So whatever you can do to get to their prominent markers is going to be beneficial to making sure you do a thorough auscultation of all areas. Other things is making sure you have high quality stethoscopes. Everywhere I've worked, I've never had to buy a stethoscope. The hospital has always provided them in their per patient room because we don't move the stethoscopes between patients. So I don't encourage you to go out and buy one unless that's approved by your hospital, but because of infection risk, I've never done that. And then really, like I mentioned, how I do the lift of my stethoscope, and so I can tune everything else out around me. I also think this is important, which we can talk about during our family education as well, but letting families know, like, I'm going to listen. It's going to take me 1 to 2 minutes to get this fully in. So if you can pause your questions so that someone's not trying to talk to you while you are also listening. And I often do that with my assessment in general. I will say, I'm going to need 5 minutes to really focus on doing a thorough assessment of your baby. I'm happy to talk to you through some of it. When I have a stethoscope in, I will need silence so that I can assess this. It would be so helpful to me if you can do some tucked hold or two-handed cares or offer the pacifier while I do this. That way, you've given them a timestamp of how long it's going to take you. Plus, you've given yourself this period to really focus in, especially when you have your ears in, your stethoscope. How often should we be auscultating? So routine assessments should be before and after you do any interventions, during each shift assessment. Your policy on your unit should tell you how often you have to do a full head to toe assessment, and that should include listening. I also listen anytime a clinical change is observed. Maybe your baby's heart rate is resting is usually 140, 145, and now it's 160, 165. I'm going to want to listen. Again, if they're having a lot of apnea, I'm going to want to listen. What am I noticing in my breath sounds? And then obviously immediately after intubation or extubation, whenever you're putting a chest tube in, maybe you've done a needle aspiration, those are times when we would want to pause and listen. How should we be documenting all of this? So we want to make sure we're talking about the symmetry and the quality of our lung sounds. That's the whole thing. You have 2 lungs, right? You've got 5 lobes, 3 on one side, 2 on the other, but you've got 2 lungs. So are they equal? Is the air entry and so on inspiration and expiration, entry and exit, equal? Are they clear on inspiration and expiration? Those are key differences that could really affect what the provider would do next. If you're hearing new crackles, maybe they got a blood transfusion that day and now they're having crackles. Maybe we need to give a dose of diuretics to pull some of that fluid off. So thinking about what the next step could be. With heart tones, I assure you there will be a time where you're listening and you've maybe had the baby for 2 or 3 shifts as your patient and you assess them, you don't hear a murmur, and then all of a sudden you do. There could be some reasons for that. We slowly increase our fluids over time, right? So if we're giving more fluids to the baby, it could then allow more fluid, circulating blood volume so that there's more fluid going through that ductus arteriosus. But don't be shocked. And I never, ever, ever, ever want you to document something because someone else did. So you're thinking to yourself, well, they heard a murmur, so the baby must have a murmur. No, you need to pause. And if you don't hear the murmur, then you don't document it. If you hear no bowel tones and someone else did, you don't want to say to yourself like, "Oh, I'm just new. I just don't hear this." First, you can grab someone else, especially if the baby looks great and you're just not hearing it, have someone else come in and assess. Or if you don't hear him and the baby doesn't look great, we need to be escalating that in the moment. Never assume just because someone else saw or heard something that you too should. And we should not be documenting something if we do not hear it. So try to get off my soapbox about that. And then be precise about what you're hearing. So where you're hearing it, what long, what your murmur might sound like, if it's loud or shrill, to get those in there. Thinking about our neuroprotective care during auscultation, whenever possible, the bell of the stethoscope should be kept in the incubator so that it's warm. We want to make sure that we are trying to swaddle or contain them so that their bodies can stay quiet while we're trying to listen so we can do it in a timely manner. If we talked about this during respiratory, if we need to listen and the respiratory therapist also needs to listen, calling them in for your cares, coordinating with your providers if they're going to be doing an assessment. Light pressure with your stethoscope. If the hydroptic babies, I would say, are some of the hardest, or babies in general that have more swelling or more fluid on their body, they can be a little bit harder to do that kind of light push. And always kind of keeping our lights dim, ambient noise down. That's just going to help with our neuroprotection. When we're talking to our parents, we want to tell them what we're listening for, why we're listening. We want to maybe tell them things that we could be listening for. We auscultate and listen to your baby's stomach to make sure that we're hearing noises, so we know that food is moving through. When we don't hear noises in their abdomen, we get concerned that maybe their gastric motility is slowed down, or we're concerned that they may have an infection called neck. We're going to do a revamp on neck this year. That's on our docket. But if you go back and watch the neck videos, I talk about how so many parents are blindsided by neck because no one ever tells them what they're looking for. So this is a great opportunity to say, these are the things we're looking for to set them up for success, what we would do for next steps. And that they should always ask, like, oh, did you hear this today? Or did you hear a murmur? I heard that the last nurse heard a murmur. Or maybe the baby's being treated for their murmur with indomethacin, not probably indomethacin, ibuprofen, acetaminophen. They might say, are you still hearing the murmur? Because they know that their baby is receiving a medication for that murmur. So things to think about, questions to anticipate that they may ask you would all be involved there. This is just a little recap slide if you want to snip it, just things to think about, what we should be hearing with our lungs, heart, and bowels, and what it could mean if we don't hear normal sounds. So this is just a little recap slide. I'll pause, let you kind of read through it, think about if you want to snip it or something. But in general, I would say the thing that we're least likely to hear is clear, equal, bilateral breath sounds, right? I think our lung sounds are the most likely to be abnormal in the scheme of kind of what we do in the NICU. So in putting this all together, we know that this is vital for us. It's vital for us to be able to have early detection. I think about the bowel tones a lot. I think about whenever you're listening and you don't hear the breath sounds on a side, the moment of panic that goes through you of like, oh my gosh, is this a pneumothorax? What's going on? Is the tube clogged? Are we right main stemmed? So the more we can do that in a neuroprotective way to really have a solid baseline for how your patient sounds that day is really going to influence kind of what the whole day goes and how we can catch things early, including our parents to help foster this trust and engagement. Remember that they are part of this is their baby, right? They are their baby's caregiver. So the more we can describe to them, there are times where parents take stethoscopes home as part of their discharge teaching. Maybe their baby's going home on a feeding tube and they need to hear the swoosh through there. Maybe their infant is going home trached and vented, and they're going to be trained to listen with a stethoscope to know more about suctioning and equal breath sounds. So the more we can kind of build up what is normal and abnormal is going to help them be successful at home. So thank you for joining me for this Teach Me Tuesday on the third Tuesday of January, where we are going over our Back to Basics and assessment parts. I hope you'll join me next week. You can find me on Instagram at my same handle, NICUeducator.Lisa. I hope you follow me there. Lots of information. You can always message me with any questions, and I hope you have a great day.